Did you know that 47.6% of shoulder pain actually comes from the neck? So if you have shoulder pain and you get an MRI that shows a rotator cuff tear, bicep tendonitis, a labral tear, the first thing that you should do is rule out the neck. But what happens is doctors want to just inject the shoulder, which won't work, or do surgery on the shoulder without determining where the pain came from. We've had many clients that had surgery, got worse after surgery, or stayed about the same that came into our office and it was a neck problem. And others who had a shoulder surgery scheduled and we were able to pull them out of the surgery because they were able to improve their symptoms enough in their shoulder in 2 to 3 visits. A big indicator that surgery is not needed is if you are not sure what you did that created your pain. These are often things that get solved with a really good physical therapist. So how can you determine if your shoulder pain is coming from your neck? Some spinal indicators are change in posture that makes you better or worse. Sitting and bending, turning, lots of movement in the neck, and numbness and tingling are all signs that this could be coming from your neck. So what are other baselines that we look at? So when someone comes in and they're complaining of shoulder pain, a lot of times they'll feel it in the front of the shoulder, they'll feel it in the back of the shoulder, they'll feel it down the side of the arm. These are good indications that you potentially might have something coming from your neck. But when you pair that with a loss of range of motion to the side that the shoulder hurts in your neck, you'll notice even if they're just like stiff and they don't really have any neck pain, we still want to rule that out. We've had clients that couldn't even barely move their arm up, and we begged to see them before they decided to have a rotator cuff surgery, but they had been through stem cell, they had been through acupuncture, physical therapy, massage, injections, and nothing worked. And the rotator cuff was torn in the MRI. And I'm like, please, please, please come in so that we can actually see you and see if this actually really is a shoulder thing, especially since you're not sure what you did. Well, she had the surgery 4 months later, was in so much pain, actually even more pain, barely could move her arm. And when she came in, we're like, there's a couple things that someone's missing. And one is definitely the neck. We want to rule it out. No neck pain, no neck stiffness. She was slightly limited on that side, not that big of a deal. We took her into some neck mobs that took her to in range to make sure, and we'll talk about those later, and got up and did the shoulder range of motion, and she was able to lift her arm up, and she goes, oh my God, and my pain reduced by like 50%. That's just off of doing one thing. And so that's why you can't just base everything off of pain location. You can't base everything even off of like range of motion. So when we look at baselines, we want to look at neck baselines. How does it move? How does it move backwards? How does it look like when you retract? We want to take shoulder baselines. Often they'll be limited in flexion. We've had people that couldn't even move their arm off like very far off their body because it hurt so much. It was still a neck issue. We look at like abduction with the shoulder. We look at extension. We look at functional internal rotation. These are all baselines that we look at because when we move you, we basically go back to those baselines to see, did it make it better? Did it make it worse? Did it not make any changes? Any one of those answers gives us information as to what we need to do next. And so it's very logical in how we figure out where things are. So another big one that we look at is called strength inhibition. And so this is something that also helps us distinguish between, is there a neck component? Is there a shoulder component? So let's what does that look like? So there are certain muscles that will get inhibited, meaning they just get weak, not because they're weak, but because the body's like, nope, there's something wrong. I don't want you to do that. And so it makes like the weakness like show. So for the neck, you'll have wrist extensors and you'll test one, it'll be like really strong. And you test the side that's hurting and it'll be like, dink, they can't even hold it. It doesn't hurt, they just can't hold it. So wrist extensors and shoulder external rotators. So you'll be testing the strength this way as well. That's inhibited in the neck. But in the shoulder, you'll only have inhibition with the shoulder external rotation. You won't have wrist extension. So if you go in, you just start testing those two things, you'll start noticing they're weak on both sides. We know there's a neck component because the wrist extensors are weak. That's not with the shoulder. So when we go and we do the motions, that we're trying to train people to see if is it a neck or is it a shoulder, and their wrist extensors get better, but their external rotators don't get better as far as like that inhibition, then you start thinking there might be a shoulder component, but let's go a little bit farther into the neck and just make sure. If a wrist extension and a external rotation actually improve as we're going through the testing, then we know it's all coming from the neck. There's definitely not a shoulder component, and they're going to be fine. But you have to go through an evaluation to figure out what it is and where it's coming from. And that's a huge piece. And that's not something that can take a 5-minute conversation with a doctor doing an image on the shoulder, especially when you're not sure what you did. So it's really important that you get to someone that really understands the body. And I just wanted to give you some insights into kind of our evaluation and our thought process and how we rule things in and rule things out based on different questions we ask you, but also based on our evaluation. So what is next? Next is, we're going to show you that in our next video. We're going to show you the baselines that are common limited and what you can do to start out to determine if your neck is really coming, if your shoulder actually is really coming from your neck, or is there a shoulder component. Now, we've had times where it's been both, and we've had times where it's only the neck, and we've had times where it's only the shoulder. But you've got to go through an evaluation process to figure out. Otherwise, you are just treating a symptom, and you could be doing surgery on something that doesn't need to have surgery, which is costly and timely. And so getting to someone that really can understand this is key in helping you feel your best as quickly as possible, but also saving you some money and time. Who doesn't want that? And that's what we do at our office. So if you're looking to work with us, there's some ways, the different ways in the description where you can get a hold of us, as well as make sure you subscribe to our channel, comment if you have any kind of questions or concerns or things that are popping up for you as well, and like and share this as well, because the more that we can get this information out to people, the more we're going to be able to help more people realize that our body is resilient, and we can actually, help, like we can actually avoid surgery, not have to go through those injections, not have to be on medications. Our body, can heal itself if you get to someone that understands it. So make sure you share this with someone that needs to hear this so that we can get the word out for people on how we can actually help them.